Thank you, Dr. Khan. Well, I'm so glad to be back. Oh my goodness, I have missed you guys. Last year I was so looking forward to coming, and then COVID happened, and I was really nervous about this year, but this is the first live thing I have been to in a year. How about you? Oh, thank you, Dr. Khan. Thank you. Thank you. Oh, the first hint of normalcy. It's just really great. And of course, seeing so many friends, people I've seen for a long time. So you're going to recognize some of the slides. But I've been tasked with talking about can we prevent diabetes. And so that's what we're going to be talking about today in this lovely room, in this lovely seminar. Uh-oh, I got cut off. Can we squish? Oh, there I am. Okay, good. I'm back. And that's me in another happy day. So we're going to talk about preventing diabetes, but first of all, this is a cardiovascular symposium, so why are we talking about preventing diabetes after all? Well, you know, globally, 415 million people have diabetes, and there's about 32.4 million in the United States. That's about 13% of the adults in the United States, but about 28%, actually, about 27% of people over 65, and that's getting to be more and more people have diabetes. And so it's really important. About 5 to 10% of people, probably more like 5% of people with diabetes have type 1, so most have type 2, but we're expecting further increases in diabetes as time goes by. At least 68% of people over 65 with diabetes are going to die of cardiovascular disease. And so that's why we're here at a cardiovascular symposium talking about trying to prevent diabetes. The mortality risk associated with diabetes, as you've heard from, I think, Dr. Wong, I know Dr. Wong, and you may have heard it several times. Mortality risk associated with diabetes for cardiovascular disease is much, much higher, and they tend to die younger, as you'll see in a later slide, about at age 50 with no history of, or no obvious cardiovascular disease. The reduced life expectancy is 6 years less at the age of 50 if you have diabetes versus not having diabetes. And it's really significant. It would be really nice if we could prevent diabetes. Oh, actually, this is the slide. And the red is the vascular deaths, and the gray is the non-vascular deaths. As you can see, it really is mostly the vascular deaths that is limiting life expectancy, and for both men and for women, this is about the number of years lost. So it's averaging about 6 years at 40 or 50 years of age, and you can see here as you get older, more and more of it is vascular premature death. Hospitalizations amongst diabetics are mostly cardiovascular. If you look at all the various cardiovascular problems, diabetics really have a lot more of them, and there are good reasons for that. About 88 million people over the age of 18 have pre-diabetes, and this is of real concern. Now, I'm talking about preventing diabetes, so by the time we've got diabetes, we're already going into those statistics. So what we really need to be talking about is pre-diabetes, and can we prevent the development of diabetes in people who have pre-diabetes. However, this means that about a third of your patients over the age of 18 have pre-diabetes, but 8 out of 10 of those people don't know that they're at risk for diabetes. And so it's hard to motivate, as we just heard, changing habits, and that was a wonderful talk. Changing habits is hard, but it's even harder if you need to change habits but don't know that you need to change habits because you don't know that you have prediabetes. So it would be really nice if we could, with lifestyle changes and eating more vegetable oils instead of meat oils. My goodness, I've never heard, I don't know of any keto people who do it with vegetable oils. I'm sorry, do you know any keto people who do it with vegetable oils? Not me. But anyway, if we could make all those nice changes, it would be really wonderful. Now, changing to fresh fruits and vegetables, and the process. Oh, I'm so glad to hear about that, because the last berry dessert I made, I was using fresh berries and ran out of fresh berries and put in frozen berries. So that was really very nice to know that it has more nutrition from the frozen berries, because they were a heck of a lot cheaper. But very good things there to know about. But a lot of people aren't going to be motivated if they don't know that they need to be making these changes in order to prevent cardiovascular disease and to prevent diabetes. So we need to let our patients know that they are at risk. We need to be checking them to see if they're at risk. And checking an A1C is an easy thing to do. And anytime you're drawing blood for any other reason, you can certainly do an A1C. You can even just do an A1C in the office. There are the office tests that are available, very cheap. The patients can do an A1C on their own. Without a prescription, they can go buy an A1C kit at the drugstore. So I'm going to do a little bit of background, and you've all heard this before, those of you who've been coming to Dr. Kahn's annual, except for 1 year, conferences for the last 14 years. A little review of how does diabetes increase cardiovascular risk. And so I wanted to talk a little bit about hyperglycemia and the role of glycated derivatives, the aldose reductase pathway, the ages, oxidative stress, and things like that. But it's going to be very, very overview here. The aldose reductase pathway is normally not active in people because it's only turned on when the blood sugar is above 180. And non-diabetics basically don't go above 180. So when you have diabetes and your blood sugar goes above 180, even if it's only briefly postprandially, it turns on the aldose reductase pathway, which leads to an increased flux. And in a conversion of glucose to sorbitol, which most obviously in the eye with causing osmotic fluxes, can contribute to the development of cataracts. And talk to any ophthalmologist, people with diabetes tend to develop cataracts earlier than people without diabetes, and that's probably one of the contributors. Also, the other pathways are involved with aldose reductase and sorbitol dehydrogenase, and the flux through this pathway will alter the redox state, leading to increased oxidation. Now, when we talk about increased oxidative stress and decreased generation of nitric oxide, which of course is allowing our blood vessels to dilate and increase blood flow, we know that people with diabetes, as a generalization, since most people with diabetes are not in optimal control, have decreased vascular dilation in response to normal stimuli. And they don't, if you blow up a blood pressure cuff, they don't dilate. A lot of things go wrong physiologically as a result of oxidative stress. Now, we know that oxidation of the lipoproteins leads to stimulation of macrophages moving in and becoming foam cells, eating up the oxidized LDL and causing atherogenesis. But what people don't think about sometimes is that you don't just oxidize lipoproteins. You can also glycate proteins. You can glycate any protein in your body. We're going to talk about that more with the next slide. But glycation does bad things to proteins, just as oxidation does bad things to proteins. But when you're talking about lipoproteins, if you oxidize your LDL, we know it's bad. It makes it more atherogenic. If you glycate your LDL, and remember, LDL is lipoprotein, protein. So it's a protein that's getting glycated. When you glycate your protein, that results in the generation of free oxygen radicals, which then leads to oxidation of other lipoproteins nearby and other proteins nearby. So by glycating one lipoprotein, that's leading to increased oxidation of others and also increased oxidation of that glycoprotein. So you end up with glycated lipoproteins, oxidized lipoproteins, and glycoxidized lipoproteins. So this is sort of like putting barbecue sauce on it and then deep fat frying it and inviting the macrophages to dinner. Either one of which would have been delicious, but put together, I mean, it's unbeatable. So we are a lipoprotein level, an LDL level that looks not too bad for somebody who doesn't have diabetes can actually be much more atherogenic than that same LDL level in a non-diabetic. So the diabetic will have much more atherogenic lipoproteins if they've been glycated and glycoxidized, okay? Another thing, this is talking about the endothelial dysfunction. And of course, hyperlipidemia, diabetes, and hypertension so often go together, and then of course lead to heart failure as well. But those three so often go together, and then they lead to all of these other oxidative stresses, which lead to the loss of vasodilation, platelet aggregation, vascular remodeling, inflammation, and smooth muscle cell growth, and breakdown of the endothelium. And I know we've talked about that before. Now, I think I've also talked before about the advanced glycation end products, but I just love talking about ages. As a matter of fact, last week, I can't even remember where I was, but I was talking to somebody sort of just out of the blue, a social talk, and we started talking about ages. I think she was talking about she wanted to get a facelift or something like that. And ages are advanced glycation end products. And they are, the ages are non-enzymatic reactions of glucose with proteins and nucleic acids, and then they become bound and become irreversible. Now, it correlates directly with the integrated area under the curve, so to speak, of your lifetime exposure to glucose. And so it correlates with chronic exposure to glucose. And if we were to do like a hemoglobin A1C every 3 months for the lifetime of an individual to sort of give us a feeling of what their entire glucose exposure was, then that would be sort of a correlation. Now, you can imagine that if you're non-diabetic and you have a lifetime average glucose of 85, compared, or say you're 50 years old, and for 50 years you've averaged 85, versus somebody who has diabetes who's 50 years old, but has a lifetime glucose exposure of 180 milligrams per deciliter on average, they are going to make advanced glycation end products much more than you did, which means they will age faster. Now, even non-diabetics have some sugar. I mean, if we're averaging 85, we're exposed to 85. So even non-diabetics age. Surprise, surprise. And so we show signs of aging, and some of those signs of aging are age spots. That's a reflection of advanced glycation end products in your skin. We also show stiffness. Who gets up in the morning and feels like, oh, I didn't feel like this when I was 19? And, we get stiffer as we get older. But people with diabetes who've had high blood sugars get stiffer faster because they are aging faster. Their tendons, their ligaments, their muscles, not to mention their eyes, their kidneys, their nerves, are all getting glycosylated and developing advanced glycation end products, which causes stiffening. This also happens in the blood vessels. But when it happens in the ligaments and the tendons, those ligaments and tendons become stiffer, and they become stiffer faster than they do in those of us who have average blood sugars of 85. I once had a ballerina come in to see me in my office. She had type 1 diabetes, and she was having trouble now because she was, not yet in the troop. She was still being groomed, so to speak. And she was having problems because she could no longer take her foot and bring it up above her head like this anymore. Now, not many of your patients are going to say that's their problem, but for her, it was a real problem. And I explained to her that probably has something to do with her aging. Now, as an example that's a lot more common, to me, as a clinician, if one of my patients who has diabetes comes in with a frozen shoulder, that's a diabetes complication until proven otherwise. Frozen shoulders are so common with diabetes, and they're getting stiff, they're getting glycosylated, they don't move as well. More commonly, though, you're probably looking for the prayer sign in your patients of long-standing diabetes. A non-diabetic person who hasn't broken the finger can put fingers side to side, skin to skin, with absolutely no gap. A person who's had poorly controlled diabetes often cannot quite close that gap, and the worse their diabetes control has been, the less able they are to close that gap. Trigger fingers are much more common in people with diabetes, again, because of glycation of the tendons and ligaments. Dupuytren's contractures are much more common in people with diabetes for exactly the same reason. So aging, the development of advanced glycation in products, is affecting the tendons, the ligaments, the nerves, the kidneys, and the blood vessels. And it's something to be aware of. Now, I think I've mentioned it before, and I'm going to say it just as an aside, because aging occurs, glycosylation of proteins. That's why when you have a turkey and you're basting it, it's dependent on the sugar, and it's also dependent on the temperature. But most people's temperature is pretty much the same all the time, so we only talk about the sugar there. If you're basting a turkey and you're putting it in at 350 degrees, the thing that makes that skin brown and crispy is advanced glycation in products in the skin. So the glycation occurs faster at high temperatures. So you get the nice crispiness in your turkey skin that you don't want in your shoulder, okay? This is what a healthy artery looks like with the intact endothelium and the intima and the smooth muscles. And this is what a diabetic endothelium will look like if they're in poor control. And quite often they're in poor control of the diabetes, the hypertension, and the dyslipidemia. So everything is happening much more rapidly. Here's another picture showing the endothelial erosion. Now, if we look at the connective tissue, we see disrupted connective tissue and a great big fat orange foam cell there, just full of glycated, oxidized, and glycoxidized LDLs. Here we show more connective tissue damage and these sort of orangish blebs that are the remnants of the foam cells that have ruptured and have released these blebs into the connective tissue. So you can imagine that that's going to encourage inflammation. And I think it's 2015 I gave a talk here on obesity, and we talked, as you just heard from your last speaker, about the immunity involved with obesity and how obese fat cells have a lot more of the inflammatory markers, inflammatory infiltrates, and can actually worsen inflammation throughout the body. Okay, so in conclusion regarding hyperglycemia, chronic hyperglycemia has deleterious effects on, I didn't show that. That was one of the 30 slides I hid when I found out I was 10 minutes shorter than I thought I was, on pancreatic beta cell number and secretory function. But I'll tell you now, because it's pertinent to the type 2 also, high blood sugars actually can lead to premature beta cell death. And so that can, being undiagnosed type 2 for years, which usually happens for years before they get diagnosed, or being pre-diabetic with abnormal glucose tolerance but not quite diabetic yet, that's also, that hyperglycemia is contributing to premature beta cell death. Hyperglycemia also, as a different function, interferes with the manufacture of insulin, not just the secretion of insulin, but actually the manufacture of insulin, the transcription of the messenger RNA for the proinsulin molecule, the cleavage of the proinsulin molecule, the secretion of the insulin molecule. So chronic hyperglycemia actually is interfering with the beta cell and with the insulin production as well. Increased formation of reactive oxygen species and advanced glycation in products is also contributing to the pathophysiology of cardiovascular disease and diabetic atherogenesis. And of course, these are promoting the development of inflammatory, thrombotic, and hypercoagulable states with atherogenic problems. So now we're moving on to the prevention of type 1 diabetes. Type 1 diabetes is increasing also in the United States, not just type 2. And we know things that really don't get talked about very much. We talk about preventing type 2 all the time with diet and lifestyle interventions. Prevention of type 1 doesn't get talked about as much, and that's why I'm going to give it the bulk of the time. We know that by preventing rubella, by getting your MMR shots and making sure your children are immunized, and make sure you're up to date on your shots if you're going to get pregnant, that really can decrease your likelihood, the baby's likelihood, of developing type 1 diabetes. In predisposed people with a family history of type 1 diabetes, it's a good idea to breastfeed for the first year of life, or at least avoid cow's milk, since there are antigens associated with cow's milk that have been thought to do a cross immunology thing with the insulin, causing insulin antibodies. And these have been found in case-controlled studies. Avoid obesity. Now that sounds like I'm talking about type 2, but actually children, when they become obese, are more likely to manifest type 1 diabetes if they are predisposed to it. And that is something, as I said, has not really generally been recognized. We know that our younger people are getting fatter all the time. And the diabetes is showing up younger. Type 1 diabetes is showing up younger in obese kids. Now we know type 2s, the obese type 2s are more likely, we're more likely to get type 2, but also type 1. And just as type 2 has doubled with the doubling of obesity, likewise type 1 has also doubled. And smoking. Smoking has been shown to be a factor that increases the likelihood of both type 1 and type 2 diabetes. And that's not just guesswork. Even secondhand smoke for the children in the family, we don't want to have them exposed to smoking. Now, the exciting thing that I'm eager to talk about today, and this is hot off the presses, and I've been anticipating it for a long time. Sabina has been trying to get my slides for weeks, and I keep saying, no, something else is coming out. Just wait, this is the something else that was coming out. The TrialNet Prevention of Type 1 Diabetes study. Now, this is the first, we've done a lot of studies that have been, didn't work. There were some of them that just sounded like they should have worked, but they didn't. So this is the first one with teplizumab, the final trial, the stage 3 trial. Right now, we're waiting for the FDA to approve it, and the FDA is supposed to say something one way or another within a month. But this is the first study to test teplizumab's ability to delay or prevent disease progression in those at high risk. Now, how do we know who's at high risk? We know who's at high risk by the Pathway to Prevention program, and I'll be giving you some references to that later. We've been doing Pathway to Prevention and its forebears for the last 40 years. I've been directly involved with Stu Soldner initially over 40 years ago when we were trying to see if we could predict who was going to come down with type 1 diabetes. And sure enough, it was quite clear it can be predicted. So if you or any of your patients have a mother, father, sister, brother, child, cousin, aunt, or uncle with type 1 diabetes, then that you can get tested for this. It's a simple blood test you have drawn at the local lab. They send it out. It doesn't cost you anything. Your insurance never knows about it unless you tell them. The lab gets paid for drawing the blood, and they send it out, and it's all done at a central laboratory. We test for 5 antibodies. Anyone who has 2 or more of those antibodies is at high risk for the developing of type 1 diabetes. So those are the subjects, those are the people, once we find those people are then offered, would you like to participate in one of our studies? And if they don't, then we ask them, would you like to be someone who we follow to determine the natural history of the disease, i.e. follow you without intervention to see how long it's going to take for you to develop type 1 diabetes. So all of these patients, or participants, had 2 or more type 1 diabetes autoantibodies, and that's because that's how we find them. We don't take people off the street. And these participants also had abnormal blood sugar levels. So that's at stage 2 of type 1 diabetes. It's pre-type 1 diabetes, but they've already progressed to abnormal, impaired glucose tolerance, but not, frankly, diabetic yet. These people at stage 2 have a virtually 100% risk of progressing to type 1 diabetes in a lifetime. And it's usually pretty quickly. It's not decades. Okay, so 76 people were enrolled in the study, ages 8 to 49, but most of them were under 18, as you would expect. They all had at least one relative with type 1 because that's how they were found. And they were assigned to the treatment group who got a 14-day intravenous course of teplizumab at the study centers, or the control group who got placebo. And they underwent oral glucose tolerance tests, I believe it was every 6 months, until either the study was completed or they developed frank clinical type 1 diabetes. In March, about a little less than a month ago, it showed an ongoing delay in development of type 1 diabetes in the teplizumab group. And the median time to diagnosis was 5 years compared to 2.3 years. So it took longer for them to develop type 1 diabetes, and some of them still haven't developed type 1 diabetes. So, of course, those people are going to be followed. But we know now that we can at least prolong the time until development of type 1 diabetes. And what we're hoping to do is to be able to find several combination therapies where we can delay it via one mechanism and another mechanism and another mechanism and another mechanism, and really, really postpone it. So they found that side effects were not bad, rash and low white cell counts, but quite tolerable. And not only did they delay the development of type 1 diabetes, but they also restored some beta cell function. So that those cells that were not dead, but only injured from the autoimmune attack, were actually able to recoup some of their beta cell function, so that the insulin production increased after treatment with teplizumab, as opposed to the natural history of the disease that was seen in the control group, which was a decline in insulin production. They're going to continue testing every 6 months until we, until we know all we can know from that. And we're hoping that by adding other things, as I mentioned, we'll be able to prolong it even more. The samples are being studied. They're being looked at, genetic markers, metabolomics, proteinomics, looking to see how to differentiate the groups who did respond versus those who didn't, to look for other mechanisms by which one can try to postpone the development of type 1 diabetes. Teplizumab was just granted breakthrough therapy designation by the FDA and the PRIME designation by the European Medicines Administration, and another study is now being done looking at teplizumab in patients who were just recently diagnosed with type 1 in hopes of being able to salvage them and give them at least give them a prolonged honeymoon period. So that study is now underway, and it's called Provention. And that was, that's just getting started. So TrialNet is conducting 2 other studies of immune therapies, one with hydroxychloroquine, our good friend, that people who never heard of it before last year now are very aware of, and a abatacept prevention study. Before I move on to the next, the hydroxychloroquine, I want to tell people the Pathway to Prevention study is still open, looking for people who might be likely to come down with type 1 diabetes. So again, first and second degree relatives of people, a proband with type 1 diabetes, the adults have to be under a certain age. It depends on what kind of an adult they are. But children and siblings, parents, aunts, uncles, and cousins. Okay, and they can get more information at trialnet.org, and that will allow them to sign up for it and get mailed screener and blood work. So moving on to the hydroxychloroquine one. Now, hydroxychloroquine's been around for 60 years, initially for malaria, but it's been used very successfully in lots of autoimmune diseases, including lupus and rheumatoid arthritis. It is approved by the FDA for use in pregnant women and in children. So it's very, very safe. It's been used extensively. It has not previously, however, been looked at as a treatment for to prevent type 1 diabetes. And the goal of this study is to find out if it can help prevent or delay progression from normal glucose tolerance to stage 2 abnormal or type 1. The hydroxychloroquine, you might think, well, okay, it's been used for these other autoimmune diseases, but why would anyone think it would work for diabetes? Well, interestingly enough, when it was being used for these other diseases, rheumatoid arthritis and lupus, it was noted that the people who had diabetes, who were now being treated with hydroxychloroquine for their autoimmune disease, their blood sugars got better. And then some small studies were done using it in people who had diabetes who didn't have autoimmune diseases, and their blood sugars seemed to get better. And this was with both type 1s and type 2s. So that is yet another reason why it was thought that this might be something to do. So this is a phase 2 trial that was a 2-arm, double-blinded, multi-center, randomized 2-to-1 placebo-controlled clinical trial using hydroxychloroquine or placebo, and 5 visits in the first 6 months, and they were doing glucose tolerance tests every 6 months. It started in 2018, and it's expected to be done around 2024. So we don't know yet. But that is something that it's easy to do. It's dosed, even the dose is, I think, slightly less than what they're using for the rheumatoid arthritis doses, and it's oral. So it's a very nice thing to know about. So I'm encouraging you to, again, encourage your patients to join the TrialNet community and get screened. Now, on to prevention of type 2 diabetes. Well, one thing we've heard about a lot today is lifestyle. And if we can make some dietary changes, that will very much help, as well as increasing our exercise. And it's really nice to know about the interval training, although I really don't like to exercise real hard. I'd rather exercise long than hard. But I'm convinced after the last speaker, I'm convinced maybe I'll try doing some of this interval stuff. So, okay. So we know very well about eating healthily, and we know more about it after the last speaker, and getting regular exercise. The DPP study with 3,234 overweight impaired glucose tolerant patients showed very well that compared to placebo, there was a 58% decrease in progression to type 2 diabetes with intensive lifestyle, and a 31% decrease in progression with medication, that being metformin for the most part. So metformin, along with no intensive lifestyle or intensive lifestyle alone without the metformin, you can see the intensive lifestyle was more effective, but the metformin was probably a little easier. Okay, so you heard 30 minutes physical exercise 5 days a week, eating healthier. We want to lose 7% of the body weight and keep it off if you're overweight. The IRIS study had 906 subjects. This is showing prevention of type 2. Smoking. No smoking. If you want to prevent type 1 or type 2, don't smoke. 25% became type 2 within 5 years, and the never smokers, 14%. So almost twice as much development of type 2 in the smokers within 5 years of entering the study. The Physicians' Health Study, with which we're all familiar, was a prospective study, and the age-adjusted relative risk was double for the development of type 2 diabetes if they were smokers compared to non-smokers. The lifestyle change, this is where I had a whole lot of structured stuff, and I was really glad that we heard it all already. So I just hid those 20 slides because we know that's what we really need to do. And actually, for the people over the age of 60 years old, there was a 58% reduction in progression to type 2 from impaired glucose tolerance with lifestyle. I mentioned metformin. Metformin is the one that has been pretty much shown to decrease progression to type 2 diabetes, but I thought I would also mention two other classes of drugs. The GLP1s in pancreatic islets. Obviously, this is not in humans. This is not in vivo. This is in vitro, but these are cultured human islets, and you can see when they are cultured in just the normal culture medium in 7 or 5 days, they're pretty dead. When they're cultured in the same medium, but it has GLP1 added, you can see that it remains, to the most part, intact. We see very similar things with the thiazolidinediones. The thiazolidinediones are not in huge favor right now because we've got so many other really good drugs that treat other things like heart failure, etc. But the thiazolidinediones, it's important to know, are particularly good for our Southeast Asians, especially in Indians and people from that area of the world because of their genetic muscle insensitivity to insulin, which is different from the average liver insensitivity in European people. Okay, I thought I would end with just throwing in something about new treatment, and I'm just going to say one new treatment for diabetes because it's pretty close to being put in front of the FDA. And this is a once-weekly basal insulin, something we can all sort of identify with, insulin. It's a phase 3 study is ongoing. It's not done yet, but there's 2 phase 2s I'm going to mention. The A1C level was reduced in those people who were on once-weekly basal insulin, went from 7.9 at baseline to 7.1 in the icodec loading dose group, 7.4 in the no loading dose group, and also in the glargine group. So there were 3 groups. One was glargine, also known as Lantus or Basaglar, and then there was the icodec that just got their standard dose every week, and there was the group that got a double dose the first week and then the standard dose. So the loading dose seems to be the most successful. Adverse events were virtually the same between groups. This came out 5 days ago. No unexpected safety problems. Hypoglycemia episodes, as you can see, were not at all of concern because none were severe, requiring assistance, and there were very few hypoglycemic groups. Another phase 2 study that was finished in insulin-naive type 2s showed that it was efficacious and safe. It was comparable to once-daily glargine. That was 247 insulin-naive patients with type 2 diabetes, and it was published in November in the New England Journal of Medicine. Another phase 2 was just published about 2 weeks ago as abstracts, and this was looking at 2 methods of switching to icodec in people who had previously been on a basal insulin. That was 154 patients, A1Cs of 7 to 10, and they were getting basal insulin and at least 1 oral agent. And these people also got the loading dose versus no loading dose versus the once-daily glargine. And their primary endpoint was the time in range. How much of the time, the 24 hours, were the subjects in the blood sugar range of 70 to 180 during the last 2 weeks of the trial. And 73% of the patients who got the loading dose icodec, take that back. The patients receiving the icodec loading dose spent 73% of the time in range. Of the people receiving icodec without the loading dose, 66% of the time they were in range, and it was virtually the same, 65% in those who got the daily glargine. So there was a statistically significant and clinically significant difference. So if you're going to give it when it comes out, it looks like we're going to want to give it as a loading dose to get people to spend most of their day in the range, the blood sugar range of 70 to 180. So that's kind of exciting. So in conclusion, diabetes is a major contributor to cardiovascular morbidity and mortality and can definitely be markedly influenced by environment, both type 1 and type 2, especially eating, exercising, and smoking for both of them. Also can be influenced by pharmacologic interventions for type 2 or type 1, metformin, thiazolidinediones, GLP1s for the type 2. For type 1, environmental factors, behavior, avoiding obesity and smoking, getting your MMR immunizations, breastfeeding, avoidance of cow's milk, and pharmacologic interventions. The first one may be becoming available within the next couple of months, which is teplizumab. So you and your patients have choices. This can affect their likelihood of developing the major, as far as I'm concerned, cardiovascular risk factor contributor. And I've got some references here, and I don't think I have time for questions. Thank you.